Я могу слайд-шоу сделать Zoom, допустим, поменьше слайд. Спасибо. Hello, everybody. For those who meet me for the first time, I'm Professor Naila Bulatova from the Department of Pharmacology and Clinical Pharmacology at the Bashkir State Medical University. I'm adjunct professor here, but I'm full-time professor also at the Jordan University, the School of Pharmacy, the Department of Biopharmaceutics and Clinical Pharmacology. So I welcome everyone who are in face-to-face lecture and also those who are attending online. My pleasure. And today we have the third lecture in the series of lectures regarding the COVID-19. And of course, as a pharmacologist, I will be focusing on the pharmacological aspects of managing the COVID-19. Today, our lecture will be regarding international treatment protocols for COVID-19. And the most prominent protocol that I will start with is from the National Institute of Health, NIH. This is the institution in the United States of America, and they are continuously updating this protocol. So this is the latest one. First of all, before understanding the recommendations, all the recommendations in any guideline that you see for asthma, for example, for diabetes, there are certain strengths of recommendation. From where do these strengths come? From the evidence. We now are practicing the evidence-based medicine, or EBM, because any recommendation should be grounded, should be very well based on the results of the clinical trials on humans, preferably on humans with the disease we are talking about. And before that, we try the drugs on the healthy volunteers also to see the safety of these drugs, to explore pharmacokinetics of these drugs. And before humans, of course, we start with the animal and in vitro studies, which means cell lines, biochemical processes, kinetics of this process. So then when the solid evidence is gathered, the group of experts who create the guideline, they provide the different strengths of recommendations. And as you can see in the slide, to the left, strengths of recommendation may be strong, A, B, moderate, which is 50-50 maybe, when you recommend this treatment, or when as a future doctor you decide about this treatment, you might be not 100% sure. And the C is optional recommendation for the statement, which means you may decide or you may not to apply this treatment. So different strengths of recommendation. When we see the A recommendation, then we are almost absolutely sure about this treatment. Yes, it should be used. All right. And as I said, these recommendations, they come from the evidence, from the studies, different studies. And the best type of clinical studies are the randomized clinical trials, RCTs, which means that very well design is applied. And we have not only the treatment, we have the control group to which we compare when there is no such treatment, or we may compare to another treatment which is old and established and so on. So the best quality of evidence is one which comes from such randomized trials. And these trials do not have any limitations. I mean, sometimes the sample size is too small. This is one of the limitations. or the difference in this trial between the treatment and the control was not statistically significant, then this is limitation. When there is no limitation, this is evidence 1. Class 2A, other randomized trials which are with limitations, or subgroup analysis of randomized trials, which is less strong evidence. And 2B, non-randomized trials. There was no randomization. What is the randomization? Probably you know, when we decide, we have all patients with COVID-19, okay? And we are deciding whether to assign them to the treatment, for example, remdesivir, an antiviral drug, or to control. How to decide? We make like a lottery. There are special software. They randomize the patients. This patient will be assigned to this group, and this patient will be assigned to the other group, and so on. So that we, as researchers, we do not decide. The software decides, the lottery, like lottery decides. And this way, this is more fair for the patients to be assigned to one group or another. So if the trial is non-randomized, no such design was applied. This is inferior quality of evidence to be, as I said. Or if this is just observational cohort studies, you just, in the real life, you see how the patients are doing. This patient received the new treatment. This patient did not receive the new treatment, but you were not assigning them. The patients by themselves were assigned. And this is less or inferior quality of evidence, as I said. And the least quality of evidence is just the expert opinion, when different doctors come and they decide, they argue, and then they say, this is just my opinion based on my clinical experience, but this is not based on the clinical trial, really. Okay, and before understanding the NIH guideline recommendations, we need to say that patients with COVID-19 or SARS-CoV-2 infection may be asymptomatic or pre-symptomatic. I have discussed in my previous lecture what is asymptomatic, when there is no clear symptoms. He looks healthy, but he is infectious. Pre-symptomatic means that at the current stage, he is not having any symptoms, but later he might develop symptoms. Okay, so these patients, they test positive for SARS-CoV-2 using a virologic test. And the most common test used is the nucleic acid amplification test, or PCR, or a rapid antigen test, which in some countries now can be used even at homes, but this is less accurate test. So these patients, they test positive, but they do not have symptoms at the current stage. Next, mild illness. Just mild symptoms of COVID-19, such as fever, insignificant fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste and smell, those symptoms that you have heard about, or God forbid, maybe some of you have experienced them. But they do not have shortness of breath, dyspnea, which is limitations of breath, or abnormal chest imaging. Their chest is normal. What is moderate illness? They have evidence of lower respiratory tract infection. And this is based on the drop in their oxygen saturation. You have probably seen on the TV, or the doctors when they measure the oxygen saturation on the finger. When this oxygen saturation is 94% or above on room air at sea level, this is moderate illness. Okay. They have low respiratory disease, but their saturation is okay. And what is severe illness? Their saturation is not okay. It is alarming when the saturation drops below 94%. This is severe illness, and definitely these patients, they should be hospitalized. Okay, we measure this at room air, at sea level, and another parameters may be a ratio of arterial partial pressure of oxygen to fraction of inspired oxygen, which is PaO2 or FiO2. When it is less than 300, this is also a severe disease. Or when the patient has a respiratory rate of more than 30 breaths per minute, or if the imaging such as X-ray of the chest or a CT scan of the chest shows more than 50% involvement of the lungs. More than half of the lung is not breathing. This is the severe disease. And what is critical illness? Individuals who have respiratory failure, septic shock, and or multiple organ involvement. First of all, we need to recognize that several approaches are used to the treatment of this viral disease. Of course, the best optimal is to find the antiviral, which will be very, very effective. But unfortunately, many antivirals that showed the effectiveness in vitro, which means in the vial, in laboratory tests, they did not prove effective on humans. And some of them showed toxicity. In general, the problem with most antiviral drugs is that they are quite toxic, because it is very difficult to find those metabolic processes that occur in the virus, but they do not occur in the humans. The problem is that this parasite, this virus, when it invades the host cell, it uses the host own metabolic processes. So the treatment is quite non-selective. Okay, different antiviral therapies have been tried at different stages, some of them only in the lab, some of them reach the clinical trials, as I said, and we can inhibit the viral entry. And this is optimal when we start this treatment early in the disease and we block the viral entry. The whole process is prevented from the beginning. And as we discussed at the earlier lectures, this viral entry occurs via specific receptor to the spike protein of the virus, which is called angiotensin converting enzyme 2, or abbreviated ACE2 receptor, and also an enzyme which helps the viral entry, which is transmembrane serine protease 2, or TMP RSS2, may be blocked by the drugs. The next step, we can block the viral membrane fusion and endocytosis, and we saw these processes in the previous lectures. Or we can block the activity of the SARS-CoV-2 chymotrypsin-like protease, abbreviated as 3CL-Pro, or we can block the RNA-dependent RNA polymerase. And because the viral replication is particularly important early in the course of the disease, the greatest effectiveness of the antiviral treatment will be during the early days, the first few days. And this is similar to other viral infections. You know, when we are talking about influenza, the Tamiflu, the life-saving drug in influenza, also will be effective, and it is recommended to be given during the first 48 hours, yes. Here, the same, because after the disease progresses and there is a hyperinflammatory state, as I said, exaggerated immune response and cytokine storm, it will be too late to start the antiviral therapy, especially when the patient reaches the critical step of the illness, critical illness. So the only drug currently approved in the United States is the remdesivir as antiviral therapies. Later on, I will talk about other antiviral drugs that are approved in Russia and some other countries. But now I'm talking about the NIH guidelines, and remdesivir is an intravenous nucleotide prodrug of adenosine analog. It binds to the viral RNA-dependent RNA polymerase and inhibits viral replication through the premature termination of RNA transcription. And let us try to watch the animation. I don't know how to minimize, actually. Извините, мы могли бы посмотреть анимацию? Вы могли бы запустить? We will try to see the animation with mechanism of action of remdesivir, as I told you. Спасибо. This is the attachment through the spike protein to the ACE2 receptor on the surface of the human cell, as you can see. After the attachment, we have the uncoating, and RNA is released. And then RNA, which is viral RNA, uses the human ribosome for the translation. Yes. Now, when it continue moves, I will comment further. This is RNA of the virus, uncoating. And the coronavirus RNA is similar to the mRNA or messenger RNA of the host. So it may be confused, and the host starts coding or transcribing the RNA. And the viral RNA polymerase that participates in this process can be blocked by the remdesivir. This is the viral RNA polymerase that processes the RNA. We have the child viral RNA and mother RNA. As you can see, the child is built through the process of RNA polymerase. And this is the newly made child viral RNA, which folds up, gains envelope again and surface protein, including S protein, and it is ready to be released. As we discussed in the previous lectures, now the new viral particles are released. So what remdesivir is doing, as we said, it blocks the RNA polymerase. It attaches specifically to the nucleotides in the RNA. This is normally forming the pairs of the nucleotides. In the mother viral RNA, we have the certain sequence, as you can see. And in the child viral RNA, also there is a certain sequence according to the pairs that can be formed, as we saw. So the remdesivir, and this is the structure of the drug, remdesivir. It is a nucleotide analog, as I said. It is confused for one of the nucleotides that should be incorporated into the RNA molecule because it is very much resembling the adenine. This is the nucleotide it is confused for. And now the remdesivir is shown as a yellow square. По-моему, мы повторяем. Okay. This is what we saw. This is repetition. Это повторяется, по-моему, нужно немножечко дальше пройти. Okay. Remdesivir again. Structure similar to adenine, one of the nucleotides. And because of this similarity, it is incorporated, remdesivir yellow square is incorporated instead of adenine. And this blocks the viral RNA polymerase because the viral RNA polymerase cannot recognize remdesivir. It is an abnormal structure. Okay, спасибо. Thank you. Now the remdesivir, why it is not widely used? Because it is only suitable for the intravenous injection. Second, it is a very, very expensive drug. One course of remdesivir, which is 5 days, requires several $1,000s. So it is currently approved by the American authority, FDA, for the treatment only of hospitalized patients with COVID-19, including pediatric patients, but those only of the age of 12 years or above, and weighing 40 kilograms or above. This is approval, but also through the emergency use authorization, which is not approval, but because we have the disaster now, it is approved also for the treatment in hospitalized pediatric patients weighing 3.5 to less than 40 kilograms or aged less than 12 years and weighing 3.5 kilograms or above. Remdesivir has such a place, it is not used in the outpatients. And also it is used for patients who are not mechanically ventilated and or not on the ECMO. ECMO is the more invasive technique I explained last time that ECMO stands for the extracorporeal membrane oxygenation, and it replaces the heart and the lungs. So it is used in the acute cardiac respiratory failure. As I said, it is used by intravenous infusion very slowly over 30 to 120 minutes on day 1, followed by 100 milligram on day 2 to 5. Treatment may be extended to 10 days in patients who do not show clinical improvement after the day 5 therapy. For mechanically ventilated patients and patients on ECMO, doses slightly differ. The regimen is 10 days. What are the adverse effects? Is it safe, for example, for pregnant ladies? The main adverse effects are gastrointestinal symptoms such as nausea, elevated transaminases, liver toxicity, prothrombin time increase, hypersensitivity reactions. And that's why we need to monitor the liver, the prothrombin time, and it might need to be discontinued if we start having the liver abnormality. ALT increases to more than 10 times the normal. The major problem with the remdesivir is that it contains the solvent or vehicle called SBECD. Accumulation of such vehicle in patients with renal impairment may result in liver and renal toxicity. So we have to be very, very cautious if the patient has impairment of these organs. So maybe we need to prefer the lyophilized powder formulation, which contains less this solvent if you have the patient with renal impairment. And it is not recommended at all if there is extreme renal impairment, which means that the eGFR is less than 30 milliliters per minute. It should not be withheld from pregnant patients because we have small data in the pregnant patients, and it was shown to be safe in contrast to some other antiviral drugs, for example, favipiravir. Probably you know, originally it was Avigan in Japan, and favipiravir, which is not existing in the States and Europe, but is used in Russia widely as a tablet in outpatients, and also in Jordan, where I come from, it is used. So favipiravir has a problem that it is teratogenic, which means it is not safe in the pregnancy and it may cause malformations in the baby. But remdesivir is safe in pregnancy so far. We have such data. Regarding the drug-drug interactions, you remember maybe in the beginning of the COVID-19 pandemic, there were 2 drugs that were so heavily used in COVID-19 patients, 2 antimalarial drugs, chloroquine and hydroxychloroquine. But now, because of disappointing results from the clinical trials, there was no benefit. These drugs are discontinued in most of the countries. But if the country still uses chloroquine or hydroxychloroquine, it may decrease the antiviral activity of remdesivir, and co-administration is not recommended. And also remdesivir is not expected to have a significant interactions with oseltamivir, which is Tamiflu. The patient may concomitantly have influenza, and you might use the Tamiflu for influenza. So there is no problem with Tamiflu or baloxavir, according to the information provided by the manufacturer. The manufacturer of the remdesivir is Gilead Sciences. Now, the very successful approach is to use the monoclonal antibodies against the spike protein, or we call them anti-SARS-CoV-2 monoclonal antibodies. And currently there are 3 antibodies approved. Actually, there are 5, but 2 of them are used as a pair, and the other one is used as solo, as monotreatment. Okay, as you can see, here we have the bamlanivimab. Mab at the suffix of the word, it always means that this is monoclonal antibody. Mab is a monoclonal antibody. So the antibody is created against the spike protein. I cannot point here on the screen, I'm sure. I'm afraid that I will move the slide. Now, You can see on the slide the virus. You see the spheric virus structure, and you see the spike protein on its surface, the S protein in the green. Now you can see below the sphere, you can see the part of the S protein is enlarged. Yes, thank you. It is enlarged. This is the part in green containing a receptor binding domain, or RBD. And you can see that these two monoclonal antibodies, bamlanivimab and another antibody, etesevimab, they bind to the receptor binding domain, different epitopes, as you can see, neighboring epitopes. These are overlapping epitopes. And the other pair, which is casirivimab and imdivimab, they also bind to the receptor binding domain. But as you can see, the epitopes to which they are binding, they are not nearby located. They are not overlapping. So this is the difference. Overlapping epitopes with the first pair of antibodies, non-overlapping epitopes with the second pair of antibodies. All right. So what is the place of these antibodies currently? The American guidelines, and by the way, if you remember, when Donald Trump was sick with COVID-19, he remarkably quickly recovered. And it was seen in the social media that he received a cocktail, certain cocktail of antibodies. At that time, these two antibodies, they were under development. So he was the part of the clinical trial, and that's why probably he has recovered very quickly. So currently the place of these antibodies is that one of these combinations are used at outpatients. So this is the difference with the remdesivir. Remdesivir, we said it is used in hospitalized patients. The two antibodies, they need intravenous administration, but only once as infusion at outpatients with mild to moderate COVID-19. Of course, doesn't mean that we should take any patient with mild to moderate COVID-19 and inject them. This will be too expensive. And this is not accessible to all people, but mild to moderate disease who are at high risk of clinical progression, as defined by the emergency use authorization criteria. What are these criteria? Which means that we select people only at high risk to progress to severe disease and inject them these antibodies. What are these criteria? We will see at the next slides. But now I would mention the doses. Bamlanivimab 700 milligram, etesevimab 1,400 milligrams, sorry. And this is always in bracket, I place the strength of recommendation. This is A, which is the strongest recommendation, but it comes not from the best clinical trials. That's why it is 2A evidence. Or casirivimab 600 plus difficult names, imdivimab 600 milligram, also the same strength of recommendation. So the treatment should be started as soon as possible. As you can imagine, when we bind with the antibody to the spike protein and we bind to the receptor binding domain of the spike protein, we prevent its binding to the host cell, and we prevent the entry of the virus into the host cell. So the earlier, the better. As soon as the patient receives positive result on a SARS-CoV-2 antigen or nucleic acid amplification test, and should be started within 10 days of symptom onset. Otherwise, it will be not effective. Okay. What are these emergency authorization criteria for high risk of progression to the severe disease? Whom should we inject these antibodies with mild to moderate disease? Those who are aged 65 years or above, those who are obese. Obesity is defined as the body mass index or BMI more than 30. You know how to calculate it. You take the height and weight and you calculate it. Diabetes, cardiovascular disease, chronic lung disease, including COPD, chronic obstructive pulmonary disease, moderate to severe asthma, interstitial lung disease, cystic fibrosis, pulmonary hypertension. Okay, other conditions that have been limited expectation to progress to the high risk, but you may consider using the antibodies in immunocompromised people. Overweight are not obese, which means that their body mass index is between normal and obesity, between 25 and 30. Chronic kidney disease, pregnancy, sickle cell disease, neurodevelopmental disorders such as cerebral palsy, some genetic metabolic syndromes, and medical conditions like tracheostomy, gastrostomy, positive pressure ventilation, which means that the patient's immunity is very weak. Also, you may consider other factors, for example, race. You know that in the United States, Black people, they have more poor outcome from COVID-19 than the white people, and this may be also considered, they may be selected for such treatment. And in children, we may also use them, for children aged 16 years or above, risk factors predictive of disease progression in adults should be used. Okay. Next, treatments. Treatments actually that may modify the immune response. We are done with the treatments that prevent the virus entry or replication. Now, the second part is the pathogenetic treatment. How can we block the exaggerated immune response that may occur? You have attended my previous lecture probably, and you know that immune response is useful in fighting the virus. This is called cytokine storm, and it destroys the lungs, it destroys many other tissues, causing the multi-organ failure and thrombotic complications and many, many others. So the new treatments are baricitinib, we will be talking about its mechanism of action, or tocilizumab. They are currently approved only in combination with dexamethasone alone, or dexamethasone plus remdesivir. You know what is dexamethasone. It is one of the old drugs that is widely used in the treatment of many other inflammatory and allergic conditions and exaggerated immune responses in other diseases. So probably you have heard when dexamethasone in spring 2020 was introduced into the clinical practice, it has saved so many lives, because dexamethasone by powerfully suppressing the immune response helps to control the exaggerated immunity. So what I'm trying to say that these two new treatments, baricitinib or tocilizumab, are addition to dexamethasone now, or they are addition to dexamethasone remdesivir combination. For whom? For any patient? No. For hospitalized patients who require oxygen support, who are on high flow oxygen or non-invasive ventilation, and evidence of clinical progression with increased markers of inflammation. What are the markers of inflammation? Probably you know from physiology or pathophysiology. For example, C-reactive protein. It is non-specific marker of any inflammation, and we can easily measure it in clinical labs. Or ESR, which stands for the erythrocyte sedimentation rate, also very simple marker, or ferritin. So what I'm trying to say, these two new treatments are reserved on patients who require oxygen support. They have evidence of severe inflammation, and they are already on dexamethasone or dexamethasone plus remdesivir. Some other opinions, but I will not go into details about that. What are the adverse effects of bamlanivimab plus etesevimab? Sorry, the slides are shifted. Actually, I've started talking about this new treatment, but somehow we have skipped the adverse effects of the monoclonal antibodies I was talking about. So I am going back to the monoclonal antibodies and I have to mention their adverse effects: nausea, dizziness, rash, pruritus, pyrexia, hypersensitivity. Of course, any biological treatment, any large molecule easily can cause hypersensitivity reaction, including anaphylaxis, infusion-related reactions, and some unexpected adverse effects, side effects may occur. But these trials were using very high doses, higher than currently. So hopefully with the current doses, these adverse effects will be minimal. The second pair of the antibodies, which is casirivimab and imdevimab, they produce less adverse effects, just hypersensitivity and some other unexpected reactions may occur. So because of these serious reactions, this means, okay, we use them in outpatients as a single infusion, but during this infusion, we need to watch the patient for any unexpected reaction, such as infusion reaction. So this is done during the infusion and for 1 hour after the infusion is completed. And fortunately, there is no drug-drug interaction so far shown for these monoclonal antibodies. And the fifth monoclonal antibody, which I did not mention so far, is sotrovimab, and it is used as a single agent. If we were talking about the previous two pairs, they are used in pairs. This monoclonal antibody is used as a solo, and you can see here the structure of this molecule, how it binds to the receptor binding motif, which is binding to the ACE2 receptor. So sotrovimab epitope is shown in yellow, receptor binding domain is shown in black, and the ACE binding interface in green. So similar to the other two couples of antibodies, sotrovimab is anti-SARS-CoV-2 monoclonal antibody, which targets a highly conserved epitope. And this is a great meaning for us. Highly conserved, it means that when there is a mutation of the virus, it is unlikely to be changed. It is highly conserved epitope. And this means that probably this monoclonal antibody, even with the newly emerging mutants, will be effective. Okay. And this is what is written actually in the second paragraph of this slide. This epitope does not overlap with sites of mutations, which are identified so far. For example, we have B117, as you know, this is alpha, B1351, this is beta, P1, which is gamma, Brazilian, and the alpha is UK, the beta is South African, as you know. We have now epsilon, I believe it is from California, and iota also is not affected. It is not mentioned the Delta virus, which is our variant of concern currently. We don't know exactly about sotrovimab, but most probably, since it is not overlapping with the other mutations, most probably it will be also resistant to the mutation in Delta virus. Okay, now I began to talk about the baricitinib. Baricitinib is one of the immunomodulators. As I told you, this is not antiviral treatment. It is designed to suppress the exaggerated immune response. And baricitinib is Janus kinase 1 or JAK1 and JAK2 inhibitor. And in combination with the remdesivir, when corticosteroids are not used, it is recommended. And dexamethasone or other corticosteroids with or without remdesivir, it can be used. And tocilizumab with dexamethasone with or without remdesivir, also this combination is possibly to be used. So these are the major treatments, and I would like again to focus on the corticosteroids. The major corticosteroid is dexamethasone, as I said. And unfortunately, some people who have heard about this treatment, including medical professionals, they start piling dexamethasone in their houses, just in case if they get COVID-19 and they start treatment at home with dexamethasone. This is wrong. Currently, the place of dexamethasone in the treatment of COVID-19 is when the patient has systemic inflammatory response that can lead to lung injury and multi-system organ dysfunction. So only in such patients you will show the benefit with dexamethasone. And this is very, very important point that I would like to explain further. As an immunosuppressant, if you start using dexamethasone in any mild to moderate case, what do? You remove the immune response, normal immune response. No, you start dexamethasone only when you see signs and symptoms of exaggerated immune response, multi-system organ dysfunction, severe systemic inflammation. Instead of dexamethasone, if it is not available, we can use others in equivalent doses. The daily dose of dexamethasone is 6 milligram, either oral or intravenous IV, or instead we can use prednisone 40 milligram, methylprednisolone 32 milligram, or hydrocortisone 160 milligram. Of course, those who study pharmacology or who have studied pharmacology, they know that corticosteroids such as dexamethasone have serious adverse effects, and we need to watch them, such as hyperglycemia, elevated blood sugar, secondary infections. And this is another reason why do not we start using dexamethasone in any patient with COVID-19, because you can predispose your patient to secondary bacterial infection. The bacteria will come, or maybe later on the fungal infection will come. You should clearly understand the place of dexamethasone. Other adverse effects are psychiatric effects, vascular necrosis, etc., and reactivation of latent infections such as hepatitis B, herpes virus, strongyloidiasis, tuberculosis. Especially strongyloides hyperinfection in tropical countries. Maybe this is important for countries such as India and Egypt. This hyperinfection may occur in patients at high risk of such actually helminthic infestation. The patients from tropical, as I said, subtropical, warm temperature regions, or those engaged in agricultural activities, or there may be also reactivation of hepatitis B virus 25 when we use these corticosteroid agents. Also, dexamethasone has some drug interactions because it is inducer of hepatic cytochrome, P450, 3A4 isoenzyme. It may reduce concentrations of some medications, including remdesivir. It is expected but not very well studied, and dexamethasone, when it is started, should be continued for up to 10 days or until the hospital discharge, whichever comes first. Now, the next breakthrough in the treatment of COVID-19 was the starting using of interleukin-6 inhibitors. Interleukin-6 is a pleiotropic, which means it has multiple functions. Pro-inflammatory cytokine produced by a variety of cell types, including lymphocytes, monocytes, and fibroblasts. And during COVID-19, as we said, in some patients, we have systemic inflammation and hypoxia. Why these complications occur in some patients and not in the others? We don't know for sure, but there are some hypotheses saying there is genetic predisposition to this exaggerated cytokine release or cytokine storm. And we know a number of cytokines involved in this cytokine storm during COVID-19 severe infection. Among them are tumor necrosis factor alpha, interleukin-1, and interleukin-6 is probably the most important cytokine involved. Also, we have the C-reactive protein, and as I mentioned, we can measure this protein laboratorily, D-dimer and ferritin. So according to this observation, it was hypothesized that if we block the interleukin-6 response or its level, it may reduce the duration and or severity of the COVID-19. And that's why there are two classes of currently approved interleukin-6 inhibitors. We have the anti-interleukin-6 receptor monoclonal antibodies, such as sarilumab and tocilizumab. Of these two, tocilizumab is used. Actually, sarilumab is still under investigation. Or another approach is the anti-interleukin-6 monoclonal antibodies, such as siltuximab, and it is also under investigation. The difference between these two is that the first two molecules, they bind to the receptor to the interleukin-6, and the last molecule, it binds to the interleukin-6 itself. But in both cases, we have the same result. We have the elimination of the interleukin-6 action, either through the receptor or through the blocking the antibodies by the drug itself. I believe it's time to make a break, 5 minutes rest, and then we'll continue our lecture. Okay. You may go to have some air. Okay, we were talking before the break about the place of the interleukin-6 inhibitors in the treatment of COVID-19. Now, the major used or approved is tocilizumab. Fortunately, why these drugs appeared quickly in the market? Because in the past and currently, they are used in the treatment of rheumatoid arthritis. So we had them. Because in rheumatoid arthritis, also interleukin-6 is important. So after the observation of interleukin-6 role, the tocilizumab was tried very quickly. And now it is recommended as a single intravenous dose as 8 milligram per kilogram, actually body weight, up to 800 milligram in combination with dexamethasone. The studies have shown that if you use tocilizumab without dexamethasone, it is not helpful, but with dexamethasone, it is helpful. These patients are recently hospitalized patients who should receive the drug within the first 3 days, who have been admitted to the intensive care unit within the prior 24 hours, and who require invasive mechanical ventilation, non-invasive ventilation, or high flow nasal cannula, oxygen with high oxygen flow, which means that not every single hospitalized patient is a candidate for tocilizumab injection. Only those who really need oxygen support in the ICU. Less recommendations for the less severely ill patients. I will not go into detail, and I have to move faster. The major fear with tocilizumab, because it is immunosuppressant, we cannot use it in the people who are already immunosuppressed. For example, those who already received immunomodulating drugs, patients also who have alanine aminotransferase 5 times higher than normal. Some other contraindications exist. Mainly these are contraindications because tocilizumab may cause further immunosuppression. Tocilizumab, I repeat again, because this is a very important piece of information, should only be given in combination with dexamethasone or alternative corticosteroid, not alone. Adverse effects of tocilizumab are neutropenia, which is decreased neutrophil count, thrombocytopenia, which is decreased platelet count, and additional different serious infections. I repeat, because it is immunosuppressant, including TB, bacterial fungal infections, bowel perforations. So regarding the pregnancy, we have positive data, which means we do not have much data. That's why currently recommendation is against using tocilizumab in pregnant ladies. Regarding the baricitinib, I have already mentioned that this is a JK1 and 2 inhibitor, Janus kinase inhibitor. This type of enzyme, Janus kinase, probably you know from physiology or biochemistry, the inhibition of this enzyme, can prevent phosphorylation of key proteins involved in the signal transduction that leads to immune activation and inflammation. One of these responses is production of the interleukin-6. So if you block this signaling inside the immune cell, this will prevent the exaggerated production of the cytokines. And this is through the phosphorylation, I repeat, and also transcription STAT proteins that are involved in vital cellular function. Okay. Baricitinib is used orally. It is selective JAK1 and JAK2, as I said, inhibitor. I already said that it is existing for the treatment of rheumatoid arthritis, and it modulates the downstream signals, as I said, through the system of phosphorylation. Interestingly, that baricitinib is not only immunomodulator, but also has some antiviral activity. Some antiviral effect is shown by blocking SARS-CoV-2 replication, and entering and infecting the lung cells is prevented by this drug. So it is both, let us say. Can we see the animation? Будьте добры, по ссылочке перейдите на видео. We will see how the JK kinase inhibitors work. Нужно, наверное, просто минимизировать вначале, а потом тогда ссылка заработает. В таком режиме не будет переходить. Спасибо. This is mechanism shown for the inflammatory bowel disease, but it is the same. We will be talking about the signaling within the T cell, which is one of the immune cells. The Janus kinase protein family, major are 1, 2, 3, and some others. They are responsible for the phosphorylation, as I said, interfering with the signaling of many pro-inflammatory cytokines. You can see the cytokine receptor and the release by the cell of the pro-inflammatory cytokine. So cytokine itself may activate the cell to produce the further cytokines. And this causes, in case of this video, inflammatory bowel disease, in other cases, rheumatoid arthritis, but in our case, in COVID-19, cytokine storm. Important cytokines are interleukin 2, 4, 7, 9, 13, 15, 17, and others. And 4 distinct cytokine receptor families, as you can see, are shown here. And they have common intracellular signaling pathway, JAK-STAT pathway. So regardless of the cytokine receptor, when the cytokine such as interleukin 1, for example, binds to its receptor, the JAK activation due to phosphorylation happens. And now the activated or phosphorylated JAK molecule, you remember JAK is Janus kinase, interferes with the docked STAT protein, which is now the ultimate step common for all the cytokine receptors. Forming STAT dimer, it may regulate the transcription of the genes in the nucleus, which are encoding for the cytokines. And depending on the cell, depending on the cytokine, the response will be produced. So tofacitinib is the major such molecule that is a JAK inhibitor. JAK activation is prevented, no phosphorylation, no receptor docking, no STAT phosphorylation, no translocation of STAT in the nucleus, no regulation of genes encoding for cytokines. Okay. Спасибо, можно перейти на слайды. All right. So we already know that immunosuppression produced by Janus kinase inhibitors will limit the inflammation or cytokine storm. And additional benefit is the antiviral activity, I repeat, through interference with the viral endocytosis, potentially into entry into the susceptible cells. Okay, I would like to move faster. Major adverse effects of Janus kinase inhibitors, major one is baricitinib, are infections, since it is immunosuppressor, and myelosuppression, which means suppression of the bone marrow, and elevation of the transaminases. These are liver enzymes. So we have liver damage, we have the damage to the bone marrow, and we have the immunosuppression. And also slightly higher risk of thrombotic events. Thrombotic events, we are aware of. These thrombotic events may be due to COVID-19 itself, they may develop due to the Janus kinase inhibitors, but this is very slight increase in the risk of thrombotic events. And some vaccines that we have studied last time also, they may predispose to thrombosis. So according to what I said, we need to watch, if we use the baricitinib, we need to watch the complete blood count for the bone marrow toxicity. With differential, we need to watch the liver function tests, transaminases. Kidney function tests should be also monitored. Screening for infections, particularly viral hepatitis and tuberculosis, and any new infection should be monitored for. So the summary of what I said, the NIH guideline recommends, according to the disease severity, the following treatments. If the patient is not hospitalized, in green, mild to moderate infection, they just use the combinations of monoclonal antibodies against the spike protein. Bamlanivimab plus, plus etesevimab or casirivimab plus imdevimab. Now, the blue one, hospitalized, but no need for supplemental oxygen and insufficient data, either use or not use remdesivir. But if there is high risk of disease progression, it is justified to use remdesivir. Now, hospitalized and patient requiring oxygen, what to do? Remdesivir, dexamethasone, edit, and dexamethasone alone when combination therapy with remdesivir cannot be used. So we have three options: remdesivir alone, dexamethasone alone, or their combination. Hospitalized and requires oxygen delivery through high flow device or non-invasive ventilation. Also, we have dexamethasone or dexamethasone plus remdesivir. And for patients who are recently hospitalized with rapidly increasing oxygen demand and systemic inflammation, we add what? Tocilizumab, which is interleukin-6 inhibitor. Hospitalized and mechanical ventilation or ECMO, dexamethasone, and patients who are within 24 hours of admission to the ICU, dexamethasone plus tocilizumab. All these treatments that we have discussed. Very shortly about the association of the COVID-19 with thromboembolism. We all know about this complication. Both arterial and venous thrombosis are possible, and this includes cerebral strokes, myocardial infarctions, limb ischemia and necrosis, sometimes requiring amputations. And this is accompanied by increase in fibrin that we can measure, fibrin degradation products, fibrinogen and D-dimer. And in some studies, if these markers were elevated, the poor clinical outcome was observed, which means the patients died if these markers were elevated, which is expected. So currently, what do they recommend is to use low molecular weight heparin, which is an anticoagulant injection, or unfractionated heparin, preferred over oral anticoagulants such as warfarin. In whom? In any patient? Let us start piling anticoagulants at our houses? No. In hospitalized, critically ill patients. In hospitalized, critically ill patients. We always, in medicine, weigh the benefit of intervention versus its harm, right? If we give anticoagulant, we increase the chance of bleeding, right? So it is justified only in hospitalized critically ill patients. In mild to moderate cases, we do not use anticoagulants. And as you can see, for non-hospitalized patients with COVID-19, anticoagulants and antiplatelets should not be initiated for the prevention of venous thromboembolism or arterial thrombosis. For hospitalized patients, prophylactic dose should be prescribed unless contraindicated, and this is a strong recommendation, class A. After discharge from the hospital, we do not continue the anticoagulants, but only for certain high VTE risk patients, we can continue them. For example, after discharge, it is not practical to give the injection. So we can move to the oral anticoagulants such as rivaroxaban, 10 milligram daily for 31 to 39 days in these patients. Some patients with very high thromboembolism risk, they may continue post-discharge VTE prophylaxis, as I said. Of course, during pregnancy, it is contraindicated to use warfarin, and otherwise we use the same heparin and low molecular weight heparin in pregnant patients. But close to the delivery, if there is other risk of bleeding, we stop anticoagulant because the risk of bleeding will outweigh the benefit of VTE prophylaxis in these patients. So these are the drugs that I have mentioned already. In lactation, if the lady is breastfeeding, what is safe to give as anticoagulant? Unfractionated heparin, low molecular weight heparin, and warfarin, because all of them do not accumulate in the breast milk. Other newer oral anticoagulants are less studied, so we do not recommend them currently because of lack of data. Now, the American guidelines, they do not have recommendations for the prevention of COVID-19 other than vaccine. I mean, pharmacological prophylaxis does not exist. For example, if the medical professional or someone had close contact, very close contact to the COVID-19 patient, in Russian guidelines, as you are going to see right now, there are several agents, pharmacological agents that can be used prophylactically, but in the American guidelines, I remember, I know one nurse, she's working in the United States, and she's having very close contact with such patients. They were trying hydroxychloroquine, it was very toxic, but there was no benefit. So they recommend against using any classes of drugs. And now for the comparison, we would move to the Russian guideline for the prophylaxis, diagnosis and treatment of new coronavirus infection, COVID-19. Currently, the version 11, you see almost every 2 months, they are updating their recommendations. And current version is 11th, which is this version I'm using, but they have already announced that very, very soon they will release the version number 12. And this new version is going to be changed dramatically because of the new mutant, the Delta variant that is prevailing now in the many countries, including Russia. Before understanding the Russian recommendations, I would briefly classify, this is the classification of the COVID-19 according to the Russian guidelines, the mild cases when the body temperature is below 38, cough, weakness, and sore throat. And there is no criteria for the moderate to severe disease. What is moderate disease? Fever above 38, respiratory rate above 22 per minute, dyspnea on exertion, and image studies showing minimal involvement of the lungs on the computer tomography of the lungs, minimal or moderate involvement on the imaging. When the oxygen saturation is below 95 and C-reactive protein is above 10 milligram per liter. What is severe course of the disease according to the Russian guidelines? When the respiratory rate is above 30 per minute, oxygen saturation is 93 or below, slightly different, right? We were saying in the American guidelines, they are mentioning 94. In Russian, 93 or below, which is almost the same. And PaO2, FiO2 ratio the same, equal or below 300 millimeter of mercury. Confusion, agitation, unstable hemodynamics, which means systolic blood pressure less than 90 or diastolic less than 60 millimeter of mercury, diuresis less than 20 milliliter per hour, and typical viral lesions on the chest CT, lung CT, and the significant involvement or subtotal involvement, which is CT 3 to 4 degree, or blood lactate level above 2 millimole per liter, or Q-SOFA score. This is the score to assess the multi-organ involvement in sepsis exceeding two items. I like this guideline because it is very, very clear and concise. And first of all, it overviews all the treatments, all the pharmacological treatments available for the COVID-19. This is the overview in the table. Favipiravir, as I told you, favipiravir is the oral drug not available in the United States or in Europe, but it is used in many countries, including Russia. Also, China tried it when they had the first outbreak in Wuhan. They started trying it. Many Middle East countries are using it, for example, Jordan, Egypt, and also Turkey. Many countries are using, but not the Western countries. The mechanism of action is the inhibition of the RNA-dependent RNA polymerase. And it is used as a tablet, and we have certain dosage regimen up to 10 days. And some of the adverse effects that I would like to mention are, in addition to hypersensitivity, we have some contraindications such as liver disease and glomerular filtration rate less than 30 milliliter per minute. And as I told you, the most serious is that it is absolutely contraindicated during pregnancy, or even if the lady is of the childbearing period and is planning her pregnancy, she should not use favipiravir. During lactation and in the age below 18 years, and other are precautions. For example, having the gout is precaution, and glomerular filtration rate between 60 and 30 milliliter per minute is precaution. And this drug can be used as outpatients. It is one of the components in the protocols for outpatient treatment in Russia, because it is easy to administer. It is tablets, unlike remdesivir, or unlike monoclonal antibodies that all need intravenous infusion. Remdesivir is the next drug, and as you can see, it is available in Russian guidelines. Its active metabolite, I repeat, also acts by inhibiting RNA-dependent polymerase of the SARS-CoV-2 virus. It is prepared as dilution with normal saline, and it is given up to 5 days, sometimes up to 10 days is used. Contraindications below the age of 18. As you can see, this Russian recommendation differs. In the United States, they use the emergency use authorization in children. Here, no. Patients with glomerular filtration rate less than 30, ALT more than 5 times upper normal limit, pregnancy and lactation, and it is contraindicated for the intramuscular use. It should be given strictly in the vein. Next, preparations that do not exist in the American guidelines are immunoglobulins, human immunoglobulins against COVID-19. Mechanism of action is binding to the SARS-CoV-2 by the antibodies of class IgG. It is prepared as a solution for infusion and given intravenously. The major adverse effects are hypersensitivity, infusion reactions, and it is limited or contraindicated at the age below 18 and older than 60 years, and also during pregnancy and lactation and in autoimmune diseases. Next very interesting approach that exists in Russia, but not in other countries, is the use of the interferons. As you know, interferons, and as we covered in the previous lectures, these are very important endogenous molecules present in our bodies that protect us against the viruses, and also they have anti-proliferative and immunomodulating properties. Many properties belong to the interferons. There are several classes of interferons, alpha, beta, and gamma. And here, what is used in Russia is the interferon alpha as immunomodulant, anti-inflammatory, and antiviral drug. And it is used as intranasal spray Probably many of you are using this gripferone spray or drops into the nose, or also we have the viferone ointments, different intranasal formulations. And as you know, the nasal cavity is the first gate for the virus to enter. So this is used mainly for the protection and also in the treatment of the mild forms of the diseases. In the pregnancy, only recombinant interferon alpha 2B is approved. Next drug, also unique for Russia, is the Umifinovir or Arbidol. Probably you have heard about this Russian drug. Originally, Arbidol is anti-influenza drug. It exists for many, many years. Since I was a medical student, Arbidol was used. But also, you know, before this coronavirus outbreak, coronaviruses were known to cause a common cold in children, right? So fortunately, we have Russian clinical studies in children with coronavirus, and it was giving positive results. That's why it was decided to try the Arbidol or Umifinovir in the current COVID-19 infection. And how does it act? It inhibits the fusion of the virus with the membrane, and also it interferes with the hemagglutinin of the virus and prevents the fusion of the lipid viral coating and the cell membrane. The route of administration is oral as capsules, and the duration is 5 to 7 days if we are talking about the treatment. Good news about the Umifinovir that it can be also used for prophylaxis. In prophylaxis, it is used less frequently, depending on the type of risk. For example, just during the outbreak, if you are aware of the spread of infection, you can use it for the short period once daily. If you were in the close contact, somebody in your house has got sick and you want to prevent this COVID-19 infection, it is given twice daily. But for the treatment, if you are actually sick, then it is given 4 times daily, as I said, during 5 to 7 days. It is contraindicated in pregnancy, however. Other preparations that I was mentioning in the American guidelines and also used in Russia are baricitinib, which is a Janus kinase inhibitor, JAK1 and JAK2, and also tofacitinib, which is the interleukin 6 inhibitor. Both are used orally as a tablet during 7 to 14 days. And we were already mentioning their adverse effects, mostly the activation of infections and also bone marrow toxicity and liver toxicity. Other preparations available in Russia, but not seen in the other guidelines, are netakimab. Netakimab, MAP always means monoclonal antibody, I repeat. It is the monoclonal antibody against the interleukin 17A, and it is given subcutaneously. And olokizumab, it is a monoclonal antibody against the interleukin 6, and it is given intravenously. And again, major troubles with these monoclonal antibodies are reactions and sometimes activation of the infections. Levilimab, tocilizumab, and sarilumab are all anti-interleukin 6 monoclonal antibodies. Some of them are for subcutaneous infusion, levilimab, tocilizumab for the intravenous infusion, and sarilumab for the also for the intravenous infusion. Again, the same spectrum of adverse effects. I will not go into details about them. Canakinumab is the interleukin 1B inhibitor. As you can see here, also the difference, we did not see the interleukin 1B inhibitors in the Western guidelines. It is prepared as a lyophilized preparation, and then it is reconstituted with the water for injection, and then mixed with the 5% glucose and given as infusion. Among the glucocorticoids, same glucocorticoids as we mentioned in the American guidelines are used, dexamethasone, methylprednisolone, and hydrocortisone. I repeat, the dexamethasone dose is 6 to 12 milligram once daily, either intravenously or it is possible to give it orally. And we have covered the adverse effects of this group of drugs. Interestingly, in Russia, also they use budesonide, which is also a glucocorticoid, but it is given as inhalation. Actually, there were some international studies that have proven, I believe that was a study in the UK, it has shown that budesonide inhalation may prevent the severe inflammation in the lungs. Of course, when we give the glucocorticoid topically, we do not have those serious systemic adverse effects, as we could see. But we have to be very cautious because patient, if he has active tuberculosis or fungal infection, viral infection of the respiratory tract or liver cirrhosis, they might experience adverse effects. We reach the anticoagulants that are used in Russia. Coagulation is very, very important, right? Same anticoagulants, same direct anticoagulants, as we said, unfractionated heparin. In addition to that, dalteparin, nadroparin, enoxaparin, which is low molecular weight heparin, parnaparin, bemiparin, and fondaparinux, all of them are used in prophylactic doses. As we said, only in hospitalized patients, we do not use them in patients. And there is also intermediate doses, which are believed to be efficacious if the patient did not develop thrombosis, but he is at high risk of development of thrombosis. We might use this dose, or there is a therapeutic dose when the patient develops actual thrombosis, then we use high therapeutic dose of these agents. We have the new oral anticoagulants, or they are abbreviated as NOACs, new oral anticoagulants, rivaroxaban, apixaban, and dabigatran. All of them are conveniently used orally. And if American guideline does not recommend after the discharge, or if we treat the patient as outpatient, the Russian guideline is different in this regard, and we will talk about this right now. So regarding this anticoagulant use, there is a very nice algorithm in the Russian guideline. They are talking about the hospitalized patient with COVID-19. Hospitalized patient with COVID-19. If the patient has already the indication for the anticoagulant treatment, he is already having medical problem that needs anticoagulation, continue them. This is the green part. The orange part in the middle is saying that the patient has no signs and symptoms of thrombosis. We are talking about the prophylaxis. If the patient has the moderate form, and he has risk factors for thromboembolism, then we give the heparin, either unfractionated or low molecular weight heparin, in prophylactic or intermediate doses. But if there is severe form of the disease, then we give the same heparin preparations, also either in prophylactic or in higher doses. And this is combined with a pneumocompression, which means we have the intermittent compression devices that are placed on the legs of the patient. And like, you know, when we measure the blood pressure, the cuff is inflated and then deflated. So these are kind of stockings. We call them intermittent compression devices. They are deflated, inflated to move the venous blood away from the lower extremities to prevent the stasis of the blood. So what I'm talking about, that if the patient is having severe COVID, we use pharmacological plus non-pharmacological methods for prophylaxis of the thromboembolism. But if there is suspicion for thromboembolism, which is the right panel, then we use the higher doses, which are therapeutic doses. And if we are talking about the prophylaxis, if the factors, risk factors continue after the discharge, we can give these agents up to 30 to 45 days. But if we are talking about the treatment, then the right side of the panel, they are continued not less than 3 months. So it depends. The doses and the duration depends on the actual thrombosis or threatening thrombosis. And regarding the outpatients, as we said, that the American guidelines, they do not recommend the use of anticoagulants after the discharge, or if the patient is not hospitalized and receives the treatment at home. Of course, the blue part is talking about the patients who have already indications to oral anticoagulants like atrial fibrillation, prosthetic valve surgery. Of course, we continue giving these drugs at home. But if we are talking about the other patients and the disease was mild, we do not require therapy with anticoagulants. And this is consistent with the American guidelines. But what is different from the American guidelines is the moderate COVID-19 plus risk factors for thromboembolism. Then we talk about the anticoagulation treatment. With anticoagulation treatment, we need to give them even in the outpatients. As a doctor, you have to be aware about the drug-drug interactions that may occur between the anticoagulants that we are talking about and the antiviral drugs or immunomodulating drugs that we can use in the treatment of COVID-19. Fortunately, we do not have red squares here. Red squares, as you can see in the footnote, means that this is absolutely contraindicated interaction. We don't have such cases. But in pink color, you can see the square, dabigatran with remdesivir. This means that there is potential interaction and we might need to reduce the doses and monitor the patient for bleeding because the interaction with anticoagulant may predispose to bleeding. We are always between two evils, as I always say. With anticoagulants, you are between thrombosis and bleeding. So if there is drug interaction that increases level of anticoagulant, you may develop bleeding. Fortunately, we have it only with dabigatran and remdesivir combination. Otherwise, yellow means that there is very weak interaction. We may ignore it, and green means that this is a safe combination. So there is no problem about this. Now, regarding the algorithms or the treatment schemes for the outpatient treatment, the Russian recommendations are clearly different from American. In American, we had for the outpatients only monoclonal antibody cocktails or monoclonal antibodies against SARS protein. Now, here in Russia, the major is favipiravir. You can see the priorities for the algorithm number one. Algorithm number one consists of 3 treatments. The first component of the treatment is favipiravir. The second component of the treatment is interferon alpha intranasally. And the third component is paracetamol, of course, as required. If the patient has fever or pain, then he takes the paracetamol or acetaminophen. Other options, umifenavir or arbidol, also with the interferon or paracetamol. And here they define what is mild disease. We have already defined what is mild form of the disease. Regarding the moderate disease, the same scheme is used. Favipiravir, interferon alpha intranasally, paracetamol, but here we add anticoagulant. This is the difference from the American guidelines. Starting from the moderate form of COVID-19 in outpatients in Russia, they start using oral anticoagulants, either rivaroxaban or apixaban or dabigatran. Regarding the hospitalized patients, the preferred scheme is favipiravir with intranasal interferon alpha and anticoagulant parenterally such as unfractionated or low molecular weight heparin. and non-steroidal anti-inflammatory drugs such as ibuprofen, if indicated. Other options, if favipiravir is not available, then umifenovir, interferon alpha intranasally, anticoagulant, and non-steroidal anti-inflammatory drug. That was in the mild form in hospitalized patient. But if the form is moderate, then in addition to the favipiravir, we start using drugs against the cytokine storm to prevent the cytokine storm. Those immunomodulators that we know, baricitinib or tofacitinib or nicotinib. Some of these options do not exist in the Western guidelines. Or some other options are available. And regarding the different combinations of monoclonal antibodies, as we could see, against interleukin-6, against interleukin-17, or interleukin-1 beta, while in the severe form, where the pneumonia and the respiratory failure or acute respiratory distress syndrome are present, then the preferred algorithm is favipiravir with interleukin-6 inhibitor tocilizumab or sarilumab, which is not available in the American guideline. Anticoagulant for parenteral use, such as unfractionated or low molecular weight heparin, and non-steroidal anti-inflammatory drugs as indicated. Some other variations are possible. It is impossible to cover all of them. And if the cytokine storm is developing, then definitely, as we said, and this is consistent with the international guidelines, we use a combination of glucocorticoid, mostly dexamethasone, with tocilizumab or sarilumab. Different other variations are available. And also another distinction of the Russian guidelines from international, we said internationally, there is no pharmacological prophylaxis of close contacts. In Russia, we have several options. If we have the contact, we are talking about the healthy people or people from the groups of risk, for example, 60 or above age or concomitant chronic diseases, then during the periods of, peaks of infection, the intranasal interferon alpha is used. As we said, sprays exist, drops, solutions, lyophilized preparations, gels or ointments. Or instead of interferon alpha, we can use oral umifenovir, which is Arbidol, during 3 weeks. But if there was a close contact, as I said, for example, you are a healthcare professional or you had a close contact at home, then we combine both options. Rather than using either of them, we add to the intranasal interferon alpha the umifenovir, which is Arbidol. And these are the references that I have used for today's lecture, both international and Russian guidelines. As I told you, we are waiting for the new version. And they will be very shortly released. Thank you very much for your attention. And we have the room for questions, a couple of minutes for questions. Do you have any questions? Or maybe we have an option for the questions online as well. Okay. Пожалуйста, если у нас есть вопросы тоже у дистантной аудитории.
Hello, can I ask a question?
Yes, sure, please.
Is it recommended to give steroids in every COVID-19 patient with elevated inflammatory markers?
You are talking about steroids, or please repeat the question again.
Steroids, ma'am, steroids.
Yes, steroids are indicated in hospitalized patients. And in hospitalized patients. In outpatient treatment, we did not see them neither in the Western or in the Russian guidelines. Because I have already explained the rationale for that, because if you give the dexamethasone, for example, to any patient It is an immunosuppressant medication, and you may suppress the normal immune response against the virus, but only when we start observing the exaggerated immune response, which is cytokine storm. This is a clear indication for using steroids.
Okay, I get it. Thank you.
You're welcome, Asya. Yes. Other questions, please? Пожалуйста. Вот, a very interesting question. Я отвечу на английском, да? The question was very interesting regarding the multivitamins or separate vitamin products or nutrients, different nutrients like zinc, you know, and vitamin C and vitamin D, omega-3. I will have a special lecture. My last lecture will be entirely devoted to the complementary and alternative medicine used in COVID-19 and their place. So may I not answer this question, but reserve it to the entirely to the last lecture. Okay. What do you think? Are they helpful against COVID-19 or not? You don't know. Might be helpful, might be not. Nobody knows, right? Okay, we will have the current information on that.
Yeah, that will be good.
Yes. Is there a question? Is there any question?
No, ma'am. Thank you.
You're welcome. Then the time is over. I will conclude today's lecture, and thank you again for listening. Stay safe and see you on Monday. Same place, right? Bye-bye.